thank you all for participating today in this online Zoom seminar, which I plan to continue to keep going. I think this is a great way for us to communicate from the comfort of your own home, and the slides will continue to work, and we won't have trouble with our big screens and have face-to-face meetings, and you can all be in very comfortable receiving information. So this is probably one of the good things that have come out of the pandemic after this whole long year. So as background, many of you early on, I submitted literature regarding allocation of scarce resources and pandemic planning that I had participated on many years ago. This image to the left was from a National Academies of Medicine panel that I was part of in 2010. And our group, Dan Hanfling specifically, had come up with, if we are in a shortage of ventilators, or in this situation, vaccine or drugs, this is the system that would be in place that would be able to allocate the scarce resource. And it requires ethical considerations, community education, all of us sharing information, doctors engaged, the community engaged. We need indicators and triggers, and I'm sure you've heard that word now, and constant process improvement. And all of public health, hospital, out of hospital care, which is our outpatient world, EMS, and local, state, and federal government all have to be a well-oiled machine in order to allocate a scarce resource. As you can tell with all our tiers and just what you're experiencing with vaccine, or what you're witnessing with vaccine delivery, which is a scarce resource. This is how, when this falls apart, all these obstacles have formed. And so that's the unfortunate part of what's going on right now. I think everybody's intentions are good. Many people have asked, how did I receive vaccine? And I know our last January 9th, I had a little bit of a debrief on exactly the difficulties we were having that first week. And now I can share with you what I've learned. I signed up for the vaccine. I assumed that all the doctors were signing up when I signed up. I figured that we all would be wanting to deliver vaccine. I signed up on, at that time it was called COVID Ready. And the minute that the site opened up, I received a call saying the state had approved me and I would be given vaccine. I got the call on Christmas Eve, so that felt great. I needed a separate freezer at the time when I was talking to folks. I'm going to pause right now just because somebody needs to mute their line. Whoops, sorry about that. If you don't mind, I think somebody's, okay, great, they're muted. Oh. If everybody could make sure their lines are muted. So there's quite a few people who joined. I'm just going to quickly mute. Terrific. So what happened was we had submitted our freezer information, which would have been adequate for the Moderna. However, there was a rule that you needed a separate one. So I rapidly got online, got a freezer in 48 hours and delivered to the office. It came in on a Sunday, believe it or not. It was very, very impressive. And it's an excellent freezer. And then the vaccine arrived. We received 100 doses, and I'm very glad that it was just 100 doses because there was a lot of technological glitches in that back end system. Hospitals were the only place that had received vaccine at that time, and they had been vaccinating since December 14th. That week, medical staff had not been offered vaccine, and my assumption was that I would be able to administer vaccine to patients because I'm an outpatient provider. But because of the tier system, I had to offer it to healthcare workers, which is fine. And we got in medical staff from over 15 offices that night, and many stayed and we vaccinated each other. To date, I have administered over 2,900 doses. And a huge thank you to our retired as well as actively participating, practicing physicians, nurses, nurse practitioners, and I've got a thank you to them at the end of this presentation. But they really, really enjoyed being in the office and vaccinating as well. Extra doses. I think you've seen a lot of information in the news media about this. And what we realized on that first or second day is the syringes that were sent with the Moderna vaccine are these fat 3 ml syringes, which have a large hub here, and it entrains a little bit of liquid. Every vaccine that is made right now has a little bit of overfill just for taking air out of this syringe, squirting a little bit out so that we don't inject air into the patient, and to accommodate for this little extra that's found in a hub. We found that if we used our tuberculosis or our 1 cc syringes, that there is no hub here that has this, twisty to twist the needle device on. It's a very low reservoir syringe, and we can actually get the dose we need without any vaccine entrained. And that was what allowed us to get 1 or maybe 2 extra doses out of every vial and give vaccine to more folks than even the doses I received. So what happened when we found out about this early on in the first or second week of January, I ordered a couple thousand of these syringes. Now they're on back order. So I feel glad that I did it. And that's all in the scarce resources. I figured this is going to become a scarce resource, might as well get on top of it. Now, this is now how the state is going to be dealing with the vaccine. And many of you have heard about this from friends, families, colleagues. Early on in our presentation in January, the top line was what we were working in, and thought, okay, they make the vaccine, the CDC decides how much California gets. California then gives it to the counties, and the counties send it to me. That's what it was. And I was reporting, it took a lot for me to get this technological glitches, but now it's all smooth and it's fine. All of this is now going on behind the scenes. And Blue Shield, if many of you have heard, now wants to get involved and manage providers' performance on vaccine. And then we still would have to request through the state, do all the same reporting, but then there's this contract that happens. They also mandate that we attach our EHR system to this online scheduling platform, and that everybody has to go through that instead of what you guys are how we did it, where you just call us up and we scheduled you. So they want you to go through all of this and then that would come back to me. And to be honest with you, I don't know that I really want to go through all of that. So I apologize if some of you are decided to wait on your vaccine. I don't think so, because 98% of my patient population has been vaccinated. But at some point, I think we're gonna just phase out. I have minimal vaccine left anyway. This is the list of things that I will have to comply with. And really, your comfort and getting vaccine into your arms was my whole purpose, as stated before. And we've met all of the targets. However, they want to use that appointment scheduling, as well as I need to bill. And I have not billed for any of our services. So I think that when this whole third-party administration thing happens in San Diego, that's where I think will be the fork in the road, where we'll just say we don't want to do that, because I want to do it for free. So I apologize in advance if that is something that makes you sad. I did put in an order for the Janssen vaccine that just came out last week, because there are some people who had received their first dose of Moderna and had a reaction. And the Janssen vaccine has been approved by the CDC for that rare situation where the first dose of Moderna created, or Pfizer, created a contraindication for the second dose, and you can use the Janssen as a dose number 2 at day 28 or later. So what is this vaccine, and how does it differ from the Moderna or the Pfizer vaccine? So the Janssen is an adenovirus vehicle delivery of the same genetic material, the messenger RNA, that is in the Pfizer and the Moderna vaccine. But it uses a common known adenovirus, which is a common cold virus that's not active, to deliver that messenger RNA into the cell, or into our cells. So you're vaccinated with this little adenovirus with that messenger RNA. The Moderna and the Pfizer just has that messenger RNA suspended in the vaccine, and you get the messenger RNA directly. This adenovirus gets incorporated, vector gets incorporated into your cell system. The messenger RNA then gets incorporated, your body reads it and creates the spike protein in your cell, and then your antibodies will be formulated against that spike protein. So it's just a different way of delivering the genetic material of the coronavirus spike protein, so that your body creates the spike protein. End result is the same. That spike protein is made by your body and you develop antibodies. And this vaccine is important because it was studied in the setting of these variants. Now, what are variants? Variants are mutations in the spike protein that have been noted throughout our world, the most concerning of which was the B117, first noted in the United Kingdom late in December, due to a rapid spread of COVID at that time. There's also a variant in South Africa called the B1.1351 and the P1 in Brazil. And yes, the Janssen vaccine is the same as the Johnson & Johnson, but the CDC has chosen to call it the Janssen vaccine. And what their thoughts are, when a mutation happens, that it may be more efficiently transmitted. It may reduce our antibody production, or our ability to fight that virus. And maybe the vaccine efficacy, VE, may be limited. The Janssen vaccine was tested in the setting of the B117. So here is a schematic of the B117 mutated coronavirus, and here's some of the mutations in the spike protein. And what happens, and this is a great schematic from Scientific American, and it just may mean that our antibody response may not recognize all of that coronavirus. So, as mentioned earlier, the B117 was the UK variant. It is now detected in over 70 countries. It is more infectious, was higher in morbidity and mortality in the UK, but that was in the unvaccinated population at that time in December, January. It is predicted to be the dominant strain in the US by the end of March. And as of March 8th, we have 262 cases in California and 3,037 in all 49 states. And as comparison, March 1st, there were 2,400 cases and 206 in California. There's active, and in February, there were only 173 cases. So it is continuing to multiply. We don't know how this modeling will be in terms of while we're also actively vaccinating. And we have found that with the B117 and vaccination efforts in place, like in the United Kingdom, there is a decrease in transmission. That is currently just by observation only. What about the B1351 variant? That's the South Africa one. That's the one where the Janssen and Johnson & Johnson vaccine has been tested, and they did find some efficacy, and I'll show you some more information on that. The P1 variant, now that's what I'm keeping my eye on. Right now, Brazil's in a huge surge, and this is the one first identified in Brazil. And we don't have any cases in California. But I do have a colleague who I've been in email contact with in Brazil, and they are in dire situations right now with patients in hallways, and they're in the midst of a huge surge. And is it because of the variant, lack of vaccine, combination of the two, behavior, leadership? It's all the guesses out there. So what about the efficacy of this Janssen vaccine, or the Johnson & Johnson vaccine? They found it's 85% effective against severe COVID. That's a very important number, including in the United States, including South African B1351 variant. It was tested while it was highly prevalent. The Moderna and the Pfizer vaccines were not tested in a highly COVID prevalent environment. And there were no COVID-19 hospitalizations or deaths after 28 days of vaccination. Now, what about moderate to severe COVID-19? It showed a 66% efficacy and protection after 2 weeks after vaccination. And in the US, they had over 19,000 people in their study, and it reflected a greater diversity in our population. And it was found to have 72% effectiveness against severe critical COVID-19. And so, and age, comorbidity status, sex, race, ethnicity, similar efficacy. There's a question whether this vaccine is safe in pregnancy. And yes, this one is indicated for pregnancy. So in terms of comparing, it's a little bit of an apples to orange comparison because of the prevalence that these vaccines were tested in. But some modeling data was extrapolated, and this is a slide from UC San Diego. And it shows that efficacy at preventing severe disease, Pfizer, Moderna have this 95, 94, nearly 100%. efficacy, but the Janssen vaccine has a near 85% effectiveness. But if you look at death, no one died who received the Janssen vaccine. So we're thinking in terms of death that this is a very good vaccine. And now about against the B117, it's a 72% effectiveness rate, and Pfizer and Moderna have a slightly better performance. And the B135 variant and P1, which is the Brazil variant and the South Africa, Janssen seems to have a better performance because the Pfizer and Moderna is unknown. So that's why the FDA approved this vaccine. And we'll see in this global experiment that we're all in how it performs. But because it is indicated in pregnancy and a broader population, and it's a one-shot deal, it is something that is important to add to our armamentarium. So here is the vaccine efficacy that support protection against emerging variants. This was by a CDC slide presentation that I took a quick screenshot of from the FDA from presentation from last Saturday. And it seems that this, we do have 95% vaccine efficacy, or 82% against severe critical illness, and a 95% efficacy against the B1351 in South Africa, 88% against severe critical illness in Brazil, and it seems to be very effective for in the United States. So more to follow. There is also something called variants of interest, and you probably will start hearing more about this. There's a variant of interest that was just mentioned last week in New York, and this is from Tuesday's reporting from the California Department of Public Health. So I want to appropriately attribute information where I've received it. So this is from a conference call that's held weekly, and there's a B1526 variant in New York. And from conversations on Monday with colleagues in Brooklyn, their ICUs are starting to fill up with the younger age population who are not in the tier to be vaccinated. And so that is a variant of interest, and maybe there is something going on, whether is it evading the vaccine effect or antibody response, or we call it vaccine evasion, or is it because that it's infecting a group of people who have gotten out into the public and they are not immunized? More to follow on that. The Western variant, the B429 and the B1427, I think in January, I'm going to pause again because I do hear somebody that's not muted. So the B1429 and B1427, we've known about this since January. I think I had mentioned that something different was happening in December. We had seen a huge surge even in my colleagues and CalMat population when we were responding to the alternate care sites. We knew what to do. We had enough PPE, but we were getting infected. And there had to be something different going on. And it was discovered in January that we had a variant in San Diego, Imperial County, and Los Angeles. And now there's studies supporting that. It now represents 60% of what is sequenced in our state. So I know it just hit the headlines in the LA Times in the last 2 weeks, but it is something we've known about. And it does seem to have an increased risk for transmission, which I mentioned, but it does not have an increase in mortality or morbidity, and no increase in viral loads. So what does it mean to be vaccinated in the setting of these variants that I've discussed with you? Well, there has been some good news um, just released by a press release on Thursday from Pfizer that has some observational data from what the Israel experience, saying that that the vaccine decreases transmission from real world evidence. And that if unvaccinated individuals were 44 more times more likely to develop symptomatic COVID and 29 times more likely to die from COVID. I don't know the data. This is a press release, and that's unfortunate that right now we're getting our scientific information from industry press releases. So we still have to see this in an academic publication that has been peer reviewed and the data has been analyzed. But this did hit the Wall Street Journal on Friday, so you may have read it. And so I wanted to bring that to your attention. Many people have asked, well, how long is the persistent or how long is this virus in the air? How is it transmitted? Well, given these variants, this is a moving target question because if the virus has mutated and somehow has made itself capable of survival in an arid environment or where a cough can and the virus is a little bit, so to speak, lighter, or it doesn't require a respiratory droplet and it can aerosolize a little bit better, then it's an unknown question. And that's what they mean by transmission. But the vaccine efficacy still looks promising against the variants. And I'm very encouraged. There's a question in regarding dermal fillers. And yes, that is a contraindication. It's not a contraindication, but in the messenger RNA vaccines that are by Pfizer and Moderna, there's a cross reactivity with dermal fillers. And if you've had one of those in the last 30 days, you may get an allergic reaction type and some facial swelling responsive to prednisone. And it's up to the individual if they want to receive that. But the Janssen vaccine, no contraindications that we know of yet. So let's move on to social activity. Now that you've been vaccinated, what does that mean? Can you do it? Yes, certainly, but it depends. It's important to know what your background positivity rate is in your community to feel comfortable getting out into that community. So this is information that was updated in the San Diego County website. It's freely accessible to everyone. I literally made this slide this morning a couple of hours ago. So it's as current as what is on the website right now, and Googled Coronado. And we are fortunately in the orange tier. Our case rate is 3.5 per 100,000. With our population of 20,000, it's an extrapolation. But the good news is I'm not having to test very many people or anybody since we've had deployed the vaccine. Sharp, if you, just as an FYI out there, has, since this pandemic started, has consistently had the highest number of COVID cases since last March. I would have to say Sharp Memorial and Sharp Chula Vista have been the leaders, the pandemic leaders. And we have a 1.3% overall mortality in San Diego, which still is consistently the lowest in the state and the lowest in the country. So it's an honor to be part of the system. I think you probably will see more headlines and publications coming out, but they've been just so busy. So no one's had time to write. So the CDC released last week, what can we do? And if you've been fully vaccinated, we had a San Diego County Medical Society call this Wednesday, and Dr. Kadakia is on the vaccine task force for San Diego, and she presented, if you've been vaccinated, you can visit with other fully vaccinated people indoors without wearing a mask or even physical distancing. You can visit with unvaccinated people from a single household who are at low risk for severe COVID-19. So that's the very important caveat, and without wearing masks. You could also not have to quarantine or test if you're asymptomatic and you've been exposed to a known COVID person. And in public, if you've been fully vaccinated, you should still continue to wear a mask. So this is increased risk for severe COVID-19. What does that mean? So the CDC, if you read just below that top recommendation I gave you, this is what they mean by those at increased risk for severe illness from the virus that causes COVID-19. Anybody with cancer, anybody with chronic kidney disease, anybody with COPD, Down syndrome, history of heart failure, coronary artery disease, or any cardiomyopathy. If you have a weakened immune system from a solid organ transplant, if your BMI is greater than 30 or 40, severe obesity greater than 40, pregnancy, sickle cell disease, smoking, if you're a smoker, and if you have type 2 diabetes. And then here are conditions that might be at an increased risk: asthma, cerebrovascular disease, if you've had a TIA or stroke, cystic fibrosis, anybody with high blood pressure, any other immune deficiency, use of steroids, for example, or any of the immune modulators. Neurologic conditions such as dementia is considered a might be increased risk, liver disease, and then anybody who's overweight, anybody with pulmonary fibrosis, thalassemia, or type 1 diabetes. So based on all of this information, it's estimated 50% of the population is at some risk for COVID-19. So until we know more about the vaccine efficacy in our at-risk population, we should still continue to wear a mask, socially distance, avoid crowds, and maintain our hand washing as best as possible. Many have asked me, what about travel? So there's this conversation going on in the lay press about a vaccine passport for travel. What is it, how it would work, who's pushing for it? Of course, the travel industry would like to see something like that. However, as of last week, the CDC still requires proof of a negative COVID if you're coming into the United States, especially from the high-risk areas where there's some variants. And many airlines are requiring negative COVID-19 testing as part of travel within 72 hours. I know that Hawaii is still requesting that. So right now, the 72 hours prior to travel, a negative COVID test, whether you've been vaccinated or not, is the consistent recommendation, because there are some privacy issues in asking if you've been vaccinated, especially because this vaccine is not an FDA approved vaccine. So you can't mandate somebody to get an unapproved vaccination. And that's why this passport's just not taking off, pardon the pun. What I'm keeping my eye on is this. There's been a report this week of 17 nursing home patients in Houston that have gotten COVID-19 after getting their vaccination. Some of them, half of them, had not received their second dose, and the other half had received the second dose, as well as 6 healthcare workers also had COVID. 3 had not received any vaccine. So more to follow. I'd like to see the actual tracings and the sequencing of that virus to find out, was it the unvaccinated healthcare workers that became spreaders of the infection throughout that nursing home? And did that impact them? Right now, they only all had mild symptoms and none of them been hospitalized. So that's the good news right now. But we need to keep our eyes on this. There have been case reports here in San Diego of healthcare workers after both doses greater than 3 weeks out from immunization getting mild COVID, and it presents like allergy or sinus symptoms. So more to follow. This is what what I'm just curious about and seeing what happens here. What does the future look like? Just last week, we found some preliminary information was released on a drug called, and I apologize if I butcher the pronunciation, molnupiravir, which is like oseltamivir, which is Tamiflu, where if you give this to a person early enough in their COVID illness, it will decrease the viral load and help prevent hospitalization. So that's very, very hopeful, because I don't know that any of us want mild COVID. Or even moderate COVID, I should say. Home test kits that are reliable would be useful so that you can test yourself in the safety of your own home. Call me, get the drug, and we can get it on board quickly. It is a pill, and they expect it out by the end of the year, which would be great, because remember, COVID, allergies, flu all present pretty much similarly. So being able to distinguish that would be useful, because is it the flu? I give you Tamiflu. Is it COVID? I give you this drug. So that's kind of where my thought process will fall in September, October, because kids are going to be back in school. And believe me, RSV, adenovirus, parainfluenza, influenza, all of those situations will exist. And if it's mild COVID, I will want to treat that, because there will be a group of people who are still at risk, who can't even handle a mild flu or mild COVID in that at-risk group that I mentioned to you. And we do not want to be transmitters of disease to them. And therefore, I will continue to be wearing a mask in the office. We have found, anecdotally, I've been talking to my other colleagues, and we haven't had to treat very much bronchitis, pneumonia, sinusitis in this whole last year because of social distancing and masking. So travel will increase by the fall, but I do think that we may become like Asia after their SARS-1 outbreak, where everybody kept wearing the masks because they noticed that their own personal infection rates had dropped. So at airports and on airplanes, I hope that the cleanliness and the distancing continues to persist. And so I think that would be great. Excuse me real quick. So I think that when you go to offices, I hope the doctors and staff continue to wear masks to protect you. Also, I think we should have continued use of the monoclonal antibodies, especially for our high-risk population, so that hospitalization is prevented. So the monoclonal antibodies are targeted therapies against the coronavirus. And we do have those available if anybody is going to get COVID, even right now after vaccination. We, in the nursing home population, people have received it even after the first dose of vaccine. I think one of the best things that has come out of this whole endeavor is an appreciation for respiratory health and wellness. I think people now know what a pulmonologist is, what a ventilator is, what the lungs are, how viruses work, how vaccines work. So I think people have developed a great medical knowledge through this, and I think that's going to carry forward for a long time to come. I still want you all, even if you have a runny nose, sneeze, congestion, let me know. I'm happy to test you, because what's going to happen is you all have been fully vaccinated. And if you do get COVID, even if it's a runny nose, we want to be able to get that swab, send it to the county, send it to the state, and get it genetically sequenced to see if it's a variant that has evaded the vaccine. So that information would be very useful. It takes a village. I thank you all for the food, water, cookies, wine, chocolates that you've all brought to the office. I want to thank Doctors Lucan, Sanford, Letterman, Flores, Lund, Mofeed, Pepper, Valletta, Barnes, Immerman, Ridge, and nurse practitioner Kim Umansky, and countless nurses who just got their vaccine and decided to stay and help immunize others. And most especially Karen and Lupita, who really made this endeavor possible, and to get 2,900 people in and out of the office. And impressively, we have had no COVID transmission despite immunizing all of those folks. So I want to thank you all. And with that, I'm going to stop sharing and open it up for some more questions. So will this presentation be up on YouTube afterwards? Yes. I'm going to go ahead and stop recording so that you can feel free to share, talk, whatever.